Good evening, guys. This is Dr. Bandhalarajan, your ADRPLEXUS Dermatology faculty. You have recently finished your INICET May exam, na? So we are going to see the dermatology recall today. There are 5 questions asked in the exam in dermatology. When I analyze the questions, out of 5, 3 to 4 were easy. One question was somewhat confusing question. We will see one by one. We will go from the difficulty from easy to difficult, so it will be good for you. The first question. Which anti-leprosy drug cause pigmentation? The options given are rifampicin, dapsone, clofazimine, or fluoxetine. These were the options given. In this question, we have discussed many times when a leprosy drug cause pigmentation means color change is caused by clofazimine due to its deposition in skin. Right? So the answer here is clofazimine. Even we have discussed this in many exams. Even in VSV, we have discussed this question. Na? Like clofazimine lead to brownish discoloration in a leprosy patient because of its deposition. Other adverse effects are, for the next exam, it will be useful for you. Like it can lead to brown sweat, dryness, ichthyosis, and all. This was a small niche or small capsule of the adverse effects of each MDT drugs. For example, if you see dapsone, it causes drug sensitivity skin rash, hemolytic anemia, and peripheral neuropathy and hepatotoxicity. If you see with rifampicin, we know rifampicin causes red colored urine. Apart from that, it can cause hepatotoxicity, thrombocytopenia, and all. Clofazimine, as I told, C for color change, means brown colored sweat, brown discoloration, you can see. Other side effects are GI side effects, dry skin, ichthyosis. So it is very important for you. Even it can be asked in the next exam also. NEET exam also, the question can be repeated. The next one, match the following. Like in the column, they have given some tests. In the column B, they have given some comments. In the column A, the options are patch test, KOH mount, slit skin smear, biopsy. In the column B, they have given contact dermatitis, leprosy, tinea corporis, and lupus vulgaris. These kind of questions are known to be asked in INICET because they will assess the multiple things in a single question. This topic we have discussed many times, like the particular test for particular disease. For example, if we see patch test, we know it is used to diagnose allergic contact dermatitis, right? So it is direct, very, very direct thing. And if you know KOH mount is useful in fungal infections like tinea corporis. Yes. And slit skin smear, we know slit skin smear we will do for leprosy. In these kind of questions, if you are able to answer at least 2 or 3 options correct, the fourth one you can identify easily. For example, for past tense, it will be A, na? 1A. There are 3 options are there. Then KOH mode, it is tinea corporis, it is C, 2C. So these 2 options are out. So this is correct, this is correct. Then slit skin smear, it is leprosy. So 3B. Then fourth, if we see biopsy, it is useful in lupus vulgaris and other infections. Okay, so 4D. So the answer here is for patch test it is contact dermatitis. For KOH mode it is tinea corporis. For slit skin smear it is leprosy. For biopsy it is lupus vulgaris. I am sure most of you got it correct because we have discussed these things multiple times. Like even in the last that subject-wise GT, we have discussed with one image of herpes labialis. We have asked what is the test you will do. In that time itself, we have discussed. Like for example, Zank smear you will use for vesicular lesions. KOH mount will use for scaly lesions or hair loss with scaling in a fungal infection. Gram Shane for pustules, crustal lesion, chancroid. Wet mount for vaginal discharge. Slit skin smear for leprosy. So if you know one or two these things, one or two of the four answers, you can identify easily. So that is the clue. The next question, which of the following vitiligo is progressive initially and then static? Option A, focal vitiligo. Option B, segmental vitiligo. Option C, acrofacial vitiligo. Option D, mixed vitiligo. We have discussed multiple times about vitiligo, but the progression and all, it is somewhat quite different question they have asked this time. We know these are the different types of vitiligo. For example, focal, there will be focal lesions here and there. Then segmental means one segment only will be involved. If it is acrofacial, it will involve the acral regions and face. In vulgaris, it can involve randomly anywhere. Universal vitiligo means it involves all over the body, right? Here, what they mention, the lesions will progress initially and then become static. So, most of you might have ruled out acrofacial and mixed vitiligo. Mixed vitiligo is nothing but it's a combination of segmental plus non-segmental vitiligo. That's all. Most of you might have excluded that, but got confused with focal and segmental. The problem with focal vitiligo is, although it is focal, there is a possibility of progression always, which is unpredictable. So it is a wrong answer here. The correct answer here is segmental vitiligo. I will tell why it is segmental vitiligo. For example, you keep in mind the segmental vitiligo involves the arm of the baby. You just keep it as an example. Arm of the baby, there is a small segmental vitiligo. If a baby grows, the arm also increases in size. So the lesion also increases in size with the proportion to the growth. When it becomes the size will become normal, the same size. So it will become static. Growth becomes static in adults. So the segmental lesion also becomes static. Because segmental vitiligo involve only one particular region. So if it increases in size based on the growth of the baby, the proportionally it will increase. If it involves the cheek, suppose if the baby become increase in weight and increase in size, the lesion also will increase up to certain age. If it become an adult, there won't be much change, so the lesion also becomes static. So the segmental vitiligo is the correct answer here. Here the lesion is there. If the person grows, the arm is like this. If it become like this, so there will be a larger lesion. So that is the way it will grow. When it becomes static, the lesion also will become static in an adult good. Right? We will move on to next question. Which STD is drug resistance out of all this? We know drug resistance in various organisms, various bacterial, fungal, and viral drug resistance. Here they are particularly asking about STD, which sexually transmitted disease is drug resistant. They are given options of syphilis, gonorrhea, chancroid, and donovanosis. In this, we know syphilis is a wrong answer because syphilis, the treatment of choice is penicillin for very long years because it is very, very effective. So drug resistance is not a possibility in syphilis. Same with chancroid and donovanosis. In STD, if they ask drug resistance, even in the midnight, if they ask you, the answer should come as gonorrhea because gonorrhea is known to have drug resistance. That's why there is a long list of drugs for gonorrhea. So gonorrhea is the one which is known to show drug resistance. So this is the trend of drug resistance in gonorrhea. Initially, they have started as sulfonamide drugs. Then because of that, penicillin become the treatment. Because of penicillin resistance, they changed to tetracycline. Then because of tetracycline resistance, they have changed to other fluoroquinolones. Because of resistance to fluoroquinolones, they have changed to cephalosporins like ceftriaxone. Because of resistance to that, they have mentioned ceftriaxone plus azithromycin as treatment. Because of resistance to these things, there are new drugs like spectinomycin. So gonorrhea and drug resistance is never ending story. So you can remember like this way. I will just give small hint here, small clue. You remember some drug resistance in TB, na? Like MDR, XDR and all. Multi drug resistance, extremely drug resistance and all. So in STD you can remember GDR, gonorrheal drug resistance. Okay, gonorrheal drug resistance. Along with this, I want to emphasize some other point. They may give other options also apart from gonorrhea. If they give gonorrhea, gonorrhea is the answer. If they are not giving, even chlamydia trachomatis can lead to drug resistance. Mycoplasma can lead to drug resistance. You know, chlamydia lead to LGV. Mycoplasma leads to bacterial vaginosis. These things also can show drug resistance. Apart from this, even Trichomonas vaginalis can lead to drug resistance, which leads to vaginal discharge. Na? Green, frothy vaginal discharge. So these are the other organisms which can cause drug resistance in STD. Gonorrhea, chlamydia, mycoplasma and Trichomonas vaginalis. Neisseria, gonorrhea. So the last question, which of the lesions, which of the condition doesn't cause annular plaque? The options here are pityriasis rosea, tinea corporis, urticaria and porokeratosis. In this everybody know tinea corporis is not the answer because it is an annular plaque. Directly we know that. Most of you got confused with these three options. And most of you even thought pityriasis rosea might not be the answer because these are round to oval plaques. Thing you might have thought of, na? So I will tell you here. Out of these four, definitely tinea corporis and porokeratosis are annular lesions. Only two things left are pityriasis rosea and urticaria. But here some twist is there because these two conditions are not known to have annular lesions always. Both of you, but can have rarely. When I searched some literature, I found out these things. Just for your information, I am just telling. Like in the annular lesions in dermatology can be caused in multiple conditions. Like in this option, you can see dermatophytosis, which is tinea corporis, is the commonest cause, right? Apart from that, you can see porokeratosis, which is also a commonest cause. But if you see in the conditions, it is given here, pityriasis rosea also can have herald patch, which is an annular lesion. Even urticaria also can cause annular lesion. So this is a tricky question because all four of them can lead to annular lesions. So here it is something like a best out of all or worst out of all. You have to select. So these two can't be the right answer here. Only we are left with pityriasis rosea or urticaria. So if you ask me, pityriasis rosea, you might have read na round to oval blocks with collarette of scales. Sometimes this appearance may lead to an annular plaque-like appearance. So, if you ask me, urticaria can be a better answer here. I won't tell this is the best answer because even urticaria can lead to annular plaques sometimes. So, the answer here is urticaria. But the answer for this question is based on their key only, because it is very, very difficult to predict, because all four can lead to annular lesions. But best out of all should be urticaria, because urticaria commonly presents like wheels. Like wheels, which are entirely elevated lesion with purely orange appearance. These are the different morphologies we have discussed multiple times. This is an annular plaque. Annular means it is like a bangle. So there will be central clearing with a peripheral elevation. If the entire plaque is elevated, it is known as nummular or discoid. The examples are discoid eczema. If there are three different zones colors, it is target lesion. Example is erythema multiforme. Thank you guys. These are the questions asked in the exam. There are some questions which are very, very easy. Some questions are very tricky. So no need to worry, because some questions they may give marks also. If there is some controversy, or based on their key, they will decide. The main thing is we can learn from the mistakes. We can correct them. So it will be useful for the upcoming NEET, which is very, very nearby. Okay, thank you guys. I hope it will be a useful session for you. Thank you. Bye.